with QHR and Roseanne Boyette from the Cibola Beacon, and your associate there next to you, what's her name?
Kara.
Thanks for being here tonight. Thank you, guys. Okay, approval of the agenda tonight. I don't think we have any changes, so it's all. Motion to approve the agenda. Second by Mr. Jennifer, all in favor? Aye. Okay. Citizens to address the board, I don't think we have anything for this tonight. Approval of consent agenda. Let's see, May 27th, 2014, June 26th, board meeting minutes. I'll give you a couple of minutes to go through it if you haven't looked at it.
I need to hear
A small correction on page 4 of our regular meeting. Motion to approve the extension of contract for Dr. Shipley, etc. Should be under regular session, not under executive session.
Oh, you're firing me.
We just draw the line in a different place. We don't take action in executive session.
Thank you for noticing that.
With that change, I'll entertain a motion to approve the consent agenda.
So moved.
Second. All in favor?
Aye.
Okay. Executive report, CEO.
On the recruitment, Dr. Weaver, we haven't heard any final commitments from him. He's the one that is doing some rotation to Zuni, and both us and the public health, the answer here, recruiting him, haven't heard anything from him. Dr. Haley Wallace, Dr. Shipley has talked to her and is interested. She's still doing her rotation and be completed with that year's rotation this month, into this month. So we should hear back from her. Dr. McIntyre, we did a telephone interview with him, and he will be his final residency starting in July, and sounded real interesting. His wife is an ER physician, and so she has some questions about the community, so we're going to get back in touch with her and explain what's going on in the community. That she can work in our ER, her own rotation with no problems, but she wants more information on the community, so we'll get in touch with her. Hunter Burston, you haven't heard, you're supposed to be coming through this area review, but they haven't yet called us back and confirmed that yet, so we're going where he is. Florentine is, we're trying to get all of his visa work done, everything to the U.S. Census, and it should be starting in July. We won't know until what date until we get all that information. We did get a notification last week that everything's in, everything is all information Dave wanted is in, so it should take 2 or 3 weeks after that respond. So it will be started, and hopefully it's something in July. Under people, so have the high performance committee meeting every Tuesday at 2:30, looking at how we can promote the hospital in retaining the good employees, recruiting the good employees, and trying to be one of the best places to work in healthcare in the state of New Mexico. And so they're coming up with some good ideas on how we can retain and keep our high performers or our X-ray should be in this week, and they're going to be doing some training on that X-ray machine. The RF room has been during taking down and construction, and we're almost through with the primary construction, and so the equipment should be arriving in the next 2 or 3 weeks. So that RF room, that's a big deal. It costs us $400,000. Let's see, quality. I think we talked about this first in the medical department, how reading and looking at our vaccination rate, hepatitis B in the hospital, and then the childhood immunization rate in the clinic, and doing a good job in that area. This month, our HCAP scores, we didn't meet our goal of 6, and Linda Maria was doing a good job trying to everybody refocus on those benchmarks, making sure that we try to improve them. And they'll go over this more in the report. But there's just hundreds of a point difference in some of these. Or if you drop just a little bit, it really drops you down. And so we're trying to figure out how we can improve those outcomes. Material management still doing a good job. Garden master review and consulting is almost complete. Just a few more items that make sure is done. Wage and salary review. That's been the portion that affects our budgets that we've already instituted those things. And so now we're going back through it and looking at some of the other policy changes or other changes that they're recommending doing. Case management is still working on their action plans, and they're almost complete with those action plans. And that's that. PI, we're doing a lean process culture, and just starting that process. And hopefully once we get that done, then we can teach the lean process to other areas and have a lot more projects on looking at quality and how we can improve those quality issues.
Any questions or comments? CMO report?
Well, Bob has successfully given my report. We are continuing to do recruiting and trying to make it as complete and effective as possible. We're continuing with review of bylaws and rules and regulations in hopes of having them completely reviewed this summer. And that's good. That's enough.
Is that it?
That's it.
Any questions for Dr. Shipley? No? Thank you, Doc.
You take a picture for 2 minutes.
No. She's call meeting.
Very easy.
COCM report?
Linda's passing something out. We thought we'd look at something different this month. We always bring you our HCAPS and quality measures. We also want to show you what else we're involved in. What she's passing out is called the Hospital Engagement Network Dashboard. And it's something that we do voluntarily participate in. And it's a quality program that measures their model or whatever it is to measure and progress towards reducing patient harm. Okay, so you'll see on the first page here, it has a lot of quality measures. These are all the people that participate in the state. These measures came out on 6/2/2014, and these are the different things that we're monitoring. Green is good, okay? Red means that we don't have enough, relevant information or enough data in those areas. Well, that's kind of, it's supposed to be red. This other one, if you put them side by side, you can see it in the bigger picture, okay? So maybe this one's easier to read, okay? Let's read that one. Green is good. I'll start over there. And you can see the little things down there. 0 says they're providing service to which the topic is relevant, not participating. 1 is we're engaged in work related to the topic, but not submitting data. 2 is engaged in work related to the topic and submitting data, don't have enough to really meet. 3 and 4 means that hospital meets all criteria for a 2 score and demonstrates improvement on the outcome. Measure for at least 3 months, okay? And then 4 is hospital meets all criteria for a 3 score and demonstrates substantial high performance. 5 is hospital meets criteria for a 4 score and meets the broad engagement criteria. So these are some of the other measures that were quality measures that we're working on. And the staff spends quite a bit of, not staff, but people that input this information to get it to them. So all of these are things that are being monitored by CMS, and so they are very important to us. This last report that came out, we are 3rd in the state, which is good. We want to be first, but we're working our way up there, but we are 3rd in the state in the participating hospitals that are doing this program. So we just wanted to share that with you. Have you seen this report before, any of the board? Okay, yeah, okay, good. So along the same lines of quality initiatives, our organization was asked to present one of our journeys in instituting bedside report. One of our nurses, Daniel Fenton, infection control last week, presented a national webinar, and which garnished our facility in the state of New Mexico some recognition. And I just wanted to pass that on because that was really good news for us to be asked to do it. And then Daniel's, he's a great nurse and good data, good speaker also, and he did that for us. So we're happy to hear that. As far as certification and education, it's a must for nursing education and certifications. We do hold monthly education classes. This month in June, we did an NRP, which is the neonatal resuscitation program, and we have 12 new certifications there. And 2 of our nursing directors, our OB and our ER, attended their individual conferences to bring information back to our staff. And they came up with some pretty good ideas, so we're excited about that.
They're both very excited with what they learned also.
Yeah.
Some new ideas and stuff for us to try to move forward with some of our scores and stuff too, so we're really excited about it.
Yeah. And as continues, we're always looking to recruit good nurses, a good fit for our team. So we have had lots of interviewing, but we don't have all our positions full.
How many positions are we?
Well, we still have a contract in OR, and we have 3 contracts on OB.
We have
We
well,
filled one.
Yeah, I was gonna say one of them is filled.
One's
We're
filled.
still working.
We've hired, we offered a job today to another OB perm, and we have another one that's coming July 2nd. And so we will be cutting those down. Every time we feel like we're getting close, and we did offer a job to an OR nurse, but every time we feel like we're getting close, something happens, so we say that cautiously. So next month we'll let you know where exactly we are. Okay? How's that sound? Is there anything in particular else you'd like us to share with you?
Maria, can you just go over these acronyms pretty quickly? That ADE and CAE, EI.
AD is adverse drug event. Okay. CAUTI is, has to deal when you have Foley catheter infection. CLABSI is like with the central line, when we place central lines for nutrition or for medications. EED is early elective delivery. And then falls in mobility, OB adverse events, pressure ulcers, bed sores. Okay. And then preventable readmissions is just, that. And then SSI is surgery site infection. VAC is ventilator assisted pneumonia. And VAE is ventilator assisted to these core measures, and that's why it's so, well, that's not why. They could cause some patient harm, but they are core measures that CMS is looking at and what our reimbursement is tied to.
Remember those, I
Means that we are submitting information to to qualify us.
No questions or comments for Brenda or you? Thank you for that information, that's good. These guys want to take a test. Barbara, QHR report?
Okay, in your packet is the Q view for this month, and it talks about home health initiatives and what hospitals are doing across the country to actually provide care in the home. We've done that for years through home health, but there's grants out there now for really coordinated care in the community where physicians go to the home, where services are provided in the home. And we, at our annual meeting a few weeks ago, we actually heard from a hospital CEO who has a program. He's fortunate that he has a lot of medical students in his community, and they're doing this through a grant, and obviously not really providing medical care, but providing just coordination for the patients, and it helps them learn how they could better serve patients once they become physicians. But there's a lot of thought that, home health through the Medicare program, you really have to be homebound. I mean, that's the definition of it. But there's a lot of people out in the community that need services that don't necessarily come to the physician, don't come to the doctor. They come to our ER perhaps, and maybe some ways to follow up on. So just some interesting concepts that we're starting to see take place around the country. And also in the packet is the QHR board minutes. And I won't go through all of this with you, but there's a pretty big article in here from iVantage Health Analytics. It's a study titled Rural Relevance Under Healthcare Reform, and it really is talking about the value proposition of rural hospitals, that the charge, the amount that Medicare pays per beneficiary is smaller for a rural patient than it is for an urban patient. And that critical access hospitals are anywhere from 1% to 2% of the total Medicare spend. I mean, critical access hospitals are very important in their communities, and they're not a big part of the dollars that are paid by the Medicare program. So it's a really interesting article if you want to read about all the different numbers, I guess, in it. But it also talks about the emergency room and how in rural areas the emergency room is much more, has less intensity of service or less acuity, because a lot of it is primary care, because of the shortage of primary care physicians in the communities. And so the number of patients in the emergency room that get converted to inpatients is lower in rural areas, which we see in everything that we look at. It also has some talk in there about the value and the quality, that the outcomes are as good or better in rural areas as they are in urban areas. It kind of debunks a lot of the myths about that urban is a lot better. So anyway, it's a really interesting article. You can read it at your leisure.
Any questions for Barbara?
And I'd just like to remind everybody about the QHR education. I know some of you are going to the new trustee education, and then we have the trustees in Savannah the next month. So.
You know what the trend is on these statistics? Are the rural hospitals receiving less than they used in the past, or is it getting better, or is it getting any?
less reimbursement in there?
Well, you said only 2% of the costs are attributable to rural hospitals, right?
Which are critical access.
Critical access hospitals,
Mhm.
and they represent 20% of the population.
So, I think that the interesting phenomenon in all of it is that our charges to the beneficiaries, so our charges to the program, or what the program reimburses the rural hospitals, is less than it is in an urban area. Our costs tend to be higher because we don't have any economy of scale if we're one hospital and we're providing every person, every service. So our costs, internal costs tend to be higher in the rural areas, but our charges tend to be lower. And so even for the same diagnosis, say pneumonia, where you could be in an urban or rural area, I mean, it's not really comparing tertiary care, but our charges and the payment, or the amount that's charged to the program ends up being less. And so part of that is not necessarily just how much we get paid. It has to do with utilization of services and so forth. Our reimbursements are going up, but neither are the urbans really either at this point.
Barbara, can you, well, first of all, welcome, I haven't seen you in a while.
I know, Tom keeps coming out here. Y'all got the CEO thing going on, so I haven't been here.
I was wondering, can you define what this sentence means? Fundamental to healthcare reforms that shift from fee to service around volume of patients to value-based purchases.
Yes, yeah, that's the core of what's going on in healthcare right now. In the past, and even largely today, we get paid for what we do. So if we do a chest x-ray, we get paid for that. If a patient comes into the hospital, we get paid for that. As a matter of fact, I was hearing on the radio just recently, someone describing this, I guess in kind of layman's terms, and said that if you had, say 5 years ago, you had a patient that you did wrong site surgery on, Medicare would pay you to fix that. You know, you got paid for doing the surgery. If you had to redo some, well, I guess you can't fix that, but okay, let's make an example. Sorry. Anyway, but let's say that you had a medical error. Then Medicare would pay you for that stay as well. And what Medicare is, through value-based purchasing, we're moving toward being paid for the value provided as opposed to the number of procedures that we did. And so that's what they talk about a lot, the value-based purchasing, which is the core measures, the HCAP scores, the readmission rates, all of those things for a prospective payment system hospital. It determines how much money they're going to get paid. And so what Medicare is trying to drive into the system is to move away from the thought process of, we'll put them in the hospital and the hospital will get paid $5,000 for pneumonia. They're trying to push back in two things. One is getting it out of the hospital in a cheaper or maybe more appropriate setting.
What you do is you put your pneumonia patient in, you don't take any x-rays, you give them one antibiotic, you don't do any labs on them, and you get them out of the hospital. And you get paid better than if you do all your x-rays, all of the, you know, it's a lose situation. It's good medical care. It's gonna stick good medical care in the dirt.
So not exactly.
Bet? How much you want to bet?
I know. Okay.
Come on, Barbara. Do the run. How much you want to bet?
I'm not.
I know you are.
It's interesting.
Well, that's the issue, is how do you measure quality care?
That's
Yeah,
what they
that's
measure
what we're
on.
using, yeah.
That's right.
Is
And
that the best measure?
that is how it's being measured. And there's going to be new measures coming out for critical access hospitals, and I don't know that it'll be significantly different. I don't really know, but
Well, just some of the measures that, I think last year, we weren't measuring the venous thrombosis. This year we are. They add, different diagnoses and stuff every now and then about what we're gonna be watching and how we're going to justify that we are giving them the best care that we can.
And eventually, the hospitals that are in the bottom quartile, and again, not critical access hospitals at the moment, but the hospitals that are in the bottom quartile of core measures, HCAP scores, readmission rates, will end up getting some pretty significant dollars taken away from them. So
Up to 6% in 2 years.
it could be something,
2016,
yeah.
6% reduction in the equal value.
And I think that's why we work so hard at it now, even though we're critical access. It's
Right.
not gonna affect us now, but I feel like in the future, it is going to affect us. So if we're a little bit ahead of the game now, then we might be in a little bit better position when it does start affecting critical access hospitals.
And you have the benefit of
So
putting the information
who
in so you
develops
get
these,
it.
these measures? Who decides?
CMS does.
Medicare.
Who is that? Who is CMS?
Medicare.
I mean, are they physicians? Are they administrators? Are they, who are they?
Well, I would,
We ask that a lot.
Do they know medicine?
I think that
Have
they,
they been to a hospital?
I don't know that I can answer that, but I think that they have looked at data for years and have made some assumptions from it, or some leaks, or however you want to look at that if we, I guess in the most basic of terms, if you took better care of the patient, they wouldn't need to be readmitted in 30 days. Now, there's a million arguments about why that doesn't necessarily logically follow, but I think that that's the conclusion that was drawn, and so therefore we're looking at readmission rates and are being penalized for having them too high.
So the whole approach right now is quality care for the dollar spent.
That's right. That's right. Instead of just, if you do it, we pay you type of approach. So fee for service means if you provide the service, they pay you the money for that. And so, and we're still in that world right now. We haven't really turned the switch. And these other things are just pieces and parts attached to it.
And there's always arguments on that issue.
All
It's
the
because
time.
of the fact that,
And
that
it's-
dollar may not have given you total quality care.
Absolutely. Absolutely.
The people you readmit are the sick people. And that's who you gotta take care of, is who is sick. I mean, the guy's got pneumonia, he cleared up a little bit, went on home, and then he just didn't make
Didn't
it.
take his antibiotics, didn't do this or whatever, went back to smoking.
So,
Which
Laura,
goes.
you kind of hide your Hippocratic oath a little bit like this, huh?
Yeah, no,
Yeah.
that's my big sin, is keeping people around.
But-
Bob, ask Bob and Jeff, the worstest person for the bottom line of this place.
Boy, I'll be the answer would be, but.
That's right, that's right. And again, back to the article about home health and care coordination is trying to recognize and put some structure in place around that patient going home and helping them not start smoking again, and helping them to take their medication and so forth. So,
And in our community, we don't have a lot of those services available to us, home health and those things like that. We don't have it.
Thank you.
you're welcome.
No PIC committee report tonight, medical staff, Dr. Jerry.
Basically, we had a meeting and we presented the people that we're gonna do and that's about it, but we didn't change anything. The rest of it is was tonight this afternoon.
Thank you, Doc. Any questions for Doc of any kind? No. Okay. Finance Committee report.
Yes,
Mr. Devon?
yes, we met today. Jeff, he's gone, I understand he went to Las Vegas City to get a better return on money.
He didn't take your. Let's get that clear.
The agenda was approved as stated, the consent agenda was approved. We reviewed the invoice, QHR invoice, and reviewed the contract log review, and found it all in order. We had a finance report.
On the back page is your financial indicators. The first one, net days and AR, you see that went up a little bit. We just have now hired our patient financial services manager, Sue Adams McCormick. She started last Tuesday and took over Arlene's duties in the hospital. And she's getting to know systems and digging into ARs. Some of that's due to our increased revenue that we had. We had increased revenue in Medicare outpatients and then in ER visits. And that kind of drove up a little bit of our ER days. You see, days cash on hand is still high. It's over the 350 mark. The volumes that you see this month, inpatient was right at budget. I think it was only $100 off on budget, but outpatient was about $380,000 above the revenue budget. So we did see an increase in volume. And you see there the excess revenue for year-to-date is right over $5 million in that area, so we're still doing real good. This month, in the financials, we didn't accrue our sole community provider payments. We don't know for sure exactly how much we're going to get to the stage yet on sole community providers. We have booked the amount that we get from July to December, but from January through June, they haven't released that information yet. We're still figuring that out. So be on the safe side, we stopped accruing that amount, and so that's why you saw a dip in the net revenue go down.
That's a big difference in our budget.
Yeah. Yeah. And the monthly net operating income was, right at break even. I think it was a little above break even. That's because of the Medicare adjustments. We had to go back and do a full cost report, Medicare cost report, to establish what our rates were through our payment system. And so with our outpatient volumes, when we have more outpatient Medicare, we have higher contractuals for those outpatients as compared to inpatients. So we have to take a little less on inpatients. So we had to readjust that calculation. So we saw a little over 100,000 more in contractuals, in Medicare, Medicaid contractuals. So that meant our net operating income was right at break even. But year to date, you still see that we're real high there. And I mean, we're over our budget. I think our budget was around 3 million. It was. So year to date, we're over our budget.
Any questions?
Just like to tell you that Jeff and I met with the county financial person on proposals for an auditor, and we ranked them, came out with a proposal for the county. So we take it, I guess, pretty quick, won't you?
Yeah.
Be on the agenda.
why don't you go over a little bit on the, what you're doing on the clinic, on the, trying to improve things on the clinic?
What we're seeing national-wide, and that's not us, but in a lot of the physician clinics, you know, they're losing money as we as hospitals put the financial information to them. And so we're in the process now, since Brenda is moving over to risk management, of getting a new new clinic administrator in that job. And so we're going out for interviews right now. We also did have QHR's clinical support team. Bob T is the head of that team. He's a physician and been working internal medicine, I think, in practice for years. And now he's on looking at how to run clinics. And so they came up and reviewed the operations of our clinic and has put together, gosh, I think about a 15-page report. It's in draft form right now, and we have a meeting next week to try to get that in final form so we can present it to you guys. And a suggestion of areas of concerns over there, areas that we need to improve on, how we need to improve, what we need to measure. Just a kind of whole in-depth analysis of clinic administration and how a clinic operates, and then giving us good ideas how to move forward in a positive manner.
Any more questions?
Any questions for Mr. Moran or Bob? Was that enough for you, Nestor?
Yeah. Well, I think the idea here is that we're looking at maybe having a kind of a performance or an efficiency audit over there to see that we're doing things the best way.
Exactly.
Just because we show a loss or no profit doesn't necessarily mean that we're doing something wrong. It obviously affects the hospital, generates revenue. But we maybe, some things, I don't know if these financials always tell us, what we're doing wrong, if we're doing anything wrong. So hopefully.
Yeah, that system we're looking at using will allow you to read a lot easier, from our point, or going down and seeing if that is, the clinic is operating efficiently and effectively, and how to measure that.
Because we've never had an assessment on it until now, right? We've never had an assessment of it.
Yeah, we had one 2-3 years ago, but it was before we moved in to the new building. Yeah, in the old place, so that's why we want an assessment over there, different, how a patient moves in and out of the system, how we can be more effective.
I make a motion to approve it.
Okay, need a second? Okay, all in favor? Aye. Okay. Need a motion to go into executive session?